This video will focus on multiple sclerosis disease-modifying therapies. This is a list of the approved disease-modifying therapies. One of the most important new concepts in disease-modifying therapy is the idea of treatment induction. In other words, starting people earlier on in the MS disease course with highly effective disease-modifying therapy. The goal of treatment, which is no evidence of disease activity, is difficult to sustain even with the best treatment. The disease-modifying therapies on the left side of this slide are those associated with the least risk. Those on the right side of the slide are associated with the greatest risk. In this second slide, showing the continuum of efficacy, you can see that the disease-modifying therapies that are associated with greater risk are also associated in large part with greater efficacy. I'll briefly review some of the newer data on the approved disease-modifying therapies, starting with glatiramer acetate. This is one of the injectable MS therapies. It works by promoting proliferation of anti-inflammatory cytokines. It's given as a subcutaneous injection 3 days a week. And we know from the GALA trial that it decreases relapses by approximately 1/3. We have data from the extension trial showing that for individuals who've been on glatiramer acetate for 15 years and longer, they tend to derive continued benefit from this medication. And it's an especially good choice for women with MS who are trying to become pregnant, and also for individuals who are particularly risk averse because it's a very safe treatment. Side effects of glatiramer acetate include skin reactions and lipoatrophy at subcutaneous injection sites. Some patients also report what is known as an immediate post-injection reaction, which can include flushing, malaise, or palpitations. It's benign and self-limited, it's not an allergic reaction, but it can be disconcerting to the patient. Beta interferon 1A comes in different forms. First, a weekly intramuscular injection that's also effective, decreasing relapse rates and disability progression by about 1/3. It has some advantages in that because it's an intramuscular injection, it tends to cause fewer skin reactions. Pegylation is a chemical process that stabilizes the molecule so that the injection can be given every 2 weeks instead of more frequently. This is also a very effective treatment for MS. And finally, beta interferon 1A comes in a 3 times per week subcutaneous injection that has been shown to, again, decrease relapses by approximately 1/3 and also decrease new MRI lesions. Beta interferon 1B is another form of injectable interferon that's given every other day and has similar efficacy to the other therapies that I just mentioned, and has shown actually some benefit in progressive MS. Adverse effects of injectable interferons include depression, migraines, and flu-like symptoms. Some patients may experience hepatic dysfunction or suppression of blood cell counts, so it's important to screen everyone with a CBC and differential and a comprehensive metabolic panel every 3 months. There are also several oral medications. The first one I'll discuss is teriflunomide. This is a daily oral medication that targets lymphocytes. We know from the TEMSO and TOWER trials that it decreases relapses by, again, approximately 1/3. Data from a 9-year extension trial were recently published showing continued benefit in patients who've been on this medication for several years. It's important when screening patients who are interested in using teriflunomide to look for tuberculosis with either a PPD or a quantiferon study to make sure that they are not at high risk of tuberculosis, and also screen a metabolic panel. And this medication should not be used in pregnancy. Dimethyl fumarate is a twice-daily oral medication that modulates immune cell balance. It decreases relapse rates by about 50%. It's important when screening patients who are going to be on this medication and when monitoring them to follow CBC and other laboratory tests. Some of the side effects that cause individuals on this medication to stop the medication prematurely include gastrointestinal side effects, and these can actually be relieved by having people take montelukast 10 milligrams daily or bismuth subsalicylate to decrease some of the GI side effects. Aspirin taken 30 minutes prior to dimethyl fumarate doses decreases flushing, which is another bothersome symptom for some patients. In my clinical practice, I find that a slow dose titration also helps decrease side effects. So patients can use the existing start kit that they receive, but rather than following the directions of the start kit, in week 1 they take 120 milligrams at bedtime. Week 2 they take 240 milligrams at bedtime. In week 3 they take 120 milligrams in the morning and 240 milligrams at night. And then from week 4 on, they can take 240 milligrams twice daily. And it's important to follow absolute lymphocyte counts, checking a CBC with differential every 6 months, as long as the initial absolute lymphocyte count is greater than 1,200. If the absolute lymphocyte count is between 600 and 1,200, I would recheck the CBC with differential in 3 months. And then if the ALC is less than 600, I would strongly consider discontinuing dimethyl fumarate. And the reason for that is that there's a risk of progressive multifocal leukoencephalopathy in patients who have leukopenia when they're on this medication. Progressive multifocal leukoencephalopathy has rarely been reported in patients on dimethyl fumarate. It appears to be related to low lymphocyte counts, so a CBC and differential should be monitored periodically. So fingolimod, or Gilenya, is another oral medication given daily, and this medication modulates immune cell migration. And we know from the Freedoms trial and the Transforms trial that it decreases relapse rates by about 50%. So similar efficacy to dimethyl fumarate. In terms of screening and monitoring, it's important to do an EKG to screen for heart block, check for varicella immunity, and do an eye exam at baseline and 3 months after starting fingolimod. And patients need to be scheduled for a first dose observation. So we know from the Freedoms 2 trial and the extension trial that were recently published that there's a sustained reduction in annualized relapse rate, loss of brain volume, and disability progression in patients who've been on fingolimod for several years. Issues to watch for in patients using fingolimod include the risk of progressive multifocal leukoencephalopathy, which is low but not negligible, as well as a rebound syndrome in which people who've been on fingolimod and discontinue it can have severe relapses. Everyone who starts on fingolimod has at least a 6-hour first dose observation when they take their first dose of the medication. And things that we watch for when doing the 6-hour first dose observation include following the patient's heart rate and blood pressure, which we measure hourly for 6 hours after they take their first dose. And we want to make sure that the heart rate is back up at least above 45 beats per minute at 6 hours after the first dose. We also do a pre- and post-dose EKG to make sure that patients after the first dose, as well as before the first dose, don't have a second degree or higher degree AV block. And we also make sure that people don't have a prolonged QT interval or symptomatic bradycardia. And if patients who are receiving a first dose observation in the office for fingolimod have any of those warning signs during the first dose observation, I'd admit them to the hospital and monitor them overnight just to be on the safe side. Some individuals shouldn't have just a simple first dose observation for 6 hours in the office. If they have ischemic heart disease, congestive heart failure, symptomatic bradycardia, heart block to begin with, or if they're taking beta blockers, digoxin, other negative chronotropic agents, or have a prolonged QT interval, any of those warning signs, some would say they should be admitted to the hospital for their first dose. I would suggest that perhaps you should look for a different disease-modifying therapy and not start them on fingolimod in the first place. Natalizumab is a humanized monoclonal antibody that targets the alpha-4 integrin molecule and prevents white blood cells from crossing the blood-brain barrier. Natalizumab is a very effective multiple sclerosis disease-modifying therapy. In a recent published study, more than 2/3 of patients actually had a sustained decrease in their expanded disability status scale score of at least 1 point, which is significant, both statistically and clinically. And some of the most common improvements we see in patient symptoms are in the areas of cognition, vision, depression, ambulation, and fatigue. The Sentinel and Affirm trials both showed that natalizumab decreases relapse rates by approximately 60%, so it's significantly more effective than the other medications we've talked about. An important component of pre-treatment screening and treatment monitoring is measuring antibodies to JC virus. We know that if individuals are JC virus negative, their risk of progressive multifocal leukoencephalopathy is 1 in 10,000 or less. If they're antibody positive, that risk increases. I test for JC virus prior to starting therapy, then every 6 months thereafter. And it's important to check the quantitative test for, which is an ELISA, for the JC virus antibody with index. We know that more than 90% of natalizumab associated PML occurs with JC virus antibody titers that are greater than 1.5. So if titers are less than 0.9, it's quite unusual to develop progressive multifocal leukoencephalopathy. Risk factors for developing PML on natalizumab include high titer JC virus antibody, prior exposure to immunosuppressive agents, which include mitoxantrone, as well as longer duration of treatment with natalizumab, which is mainly an issue if JC virus antibody is positive. After patients have been on natalizumab for induction of more than 18 months, you can actually start extending their dose intervals up to 6 weeks rather than 4 weeks apart, which may reduce PML risk without significantly reducing the efficacy of the medication. It's important to plan when you're going to stop the medication. We do know that relapses can occur when natalizumab is discontinued, and they can be severe relapses. While it's great news that we have so many FDA-approved MS disease-modifying therapies, one challenge is how to switch people from one therapy to another. We'll have more data in the next few years from various switch trials. This slide illustrates some data that were presented at a recent poster presentation on switching people who've been on natalizumab to teriflunomide, which looked positive. Finally, I'd like to discuss alemtuzumab or Lemtrada. This is a very effective MS disease-modifying therapy. It's given by intravenous infusion once a year, and that's quite convenient for patients. On the flip side, the side effects, including sometimes severe immune suppression, can last for years, so patients have to be monitored for a number of years after they finish this therapy. So this is usually given only at tertiary care MS centers. People living with secondary progressive multiple sclerosis often ask about what treatment they can be on that will be effective for them. And it can be difficult to answer that question because, as you know, there is not a strong evidence basis for most treatments for secondary progressive MS. However, there are some data reflected on this slide showing a modest benefit of several different treatments. So if patients have no contraindication to being on a therapy and they want to be on a therapy, I usually offer them one of these options. And finally, in the development pipeline for new MS disease-modifying therapies, there are a lot of exciting new options coming down the pipeline. And one of them is ocrelizumab, which is another monoclonal antibody infusion that is being currently studied in the OPERA-1 and 2 trials for relapsing MS, as well as a trial for primary progressive MS, which has shown actually some positive preliminary findings. It's very exciting. Laquinimod is another medication in the development pipeline that prevents inflammation-induced neurotoxicity and appears to have a very favorable side effect profile. There's some exciting research going on with anti-LINGO monoclonal antibodies and other remyelinating agents. And people with MS often ask about stem cell transplant. This is another very promising technology that is still in clinical trials and is showing some very positive preliminary results. The data on disease-modifying therapy for children with MS is quite limited. There are some published retrospective studies, for instance, of glatiramer acetate in children and also beta interferons. It's fine to use adult doses of the medications for children and adolescents older than 10 years old. In
In addition, observational data have been published on the use of natalizumab in patients under age 18 who have more aggressive MS. Fingolimod is also being studied in patients over 10 years of age.
It's important to identify MS exacerbations promptly because we think there's about a 2-week window, more or less, to treat exacerbations so as to reduce ongoing disability afterward. So when I talk with someone who I think is having an MS exacerbation, I first look for pseudo-exacerbations. For instance, if someone has an occult urinary tract infection or another infection, it's important to diagnose and treat that as well. And once you've identified that the person is having an MS exacerbation, very often the go-to drug is methylprednisolone, given at a dose of 1 gram intravenously daily for 3 days to 5 days, depending on the severity of the exacerbation. This can often be done with home health in the patient's home, very convenient, or at an infusion center, sometimes in the hospital if need be. And we do know that high-dose IV methylprednisolone is more effective at a dose of 1,000 milligrams daily than 500 milligrams daily. And I did want to point out that there's no evidence basis for using long-term low-dose steroids such as prednisone for long periods of time. It's shown no benefit in a clinical trial and does cause significant harm to patients from steroid side effects.
For MS exacerbations, an alternative to using intravenous methylprednisolone is dexamethasone, 50 milligrams intravenously daily for 3 to 4 days.
Another option for patients who either don't respond well to intravenous steroids or have some contraindication to intravenous steroids is ACTH or Acthar, which is now available in a gel forms for self-injection. And as you can see from the slide, some of the trials that we use to base our therapy with this medication are older trials from the 1980s. ACTH was actually used for MS exacerbations quite frequently in the 1980s until it was tested against intravenous solumedrol and found to be equivalent. So since solumedrol is less expensive, it was often, has often been used since then instead of ACTH. However, ACTH has come back on the market and it is available. It can be very helpful, as I mentioned, in people who for some reason can't use or didn't respond to IV steroids, and is given in a 5-day self-injection subcutaneous course at home. So in patients who have severe demyelinating disease attacks, you may need to go to even more effective treatment with more side effects potentially, such as plasma exchange. So if you have someone with a catastrophic demyelinating event, especially if they didn't have much baseline disability, plasma exchange can be very effective in helping that individual get over that exacerbation with minimal residual disability.
There have been some very interesting data published recently about comorbidities and MS outcomes. Some of the conditions that often co-occur with MS include hypertension, diabetes, heart disease, fibromyalgia, depression, anxiety, bipolar disorder, and chronic lung disease. The effects of these comorbidities are important and include faster MS disease progression, increased all-cause mortality, and a decreased quality of life.
In the next video, I'm going to talk about multiple sclerosis symptom management.